before lunch, John asked me if I wanted to put my slides on the computer here, and I declined because I didn't. Originally from Belgium, I didn't want to be in the way between Great Britain and Germany. We have learned our lesson from the past. I don't think I have to introduce. I don't think I have to introduce Richard Baum, which I met the first time last year in Toronto, and I owe him big time because he approached me and said we need to work on a neuroendocrine database, and I've tried to slip under the radar to avoid him over the past year. I don't think I can avoid him any longer now, so we'll have to have a little chat. So without any further ado, Richard, please.
Thanks so much to CNETS Canada, to Maureen, Jim, Sylvia for meeting me at the airport. It's nice because she has a German background and we can talk even in German. Maureen, I think I met you first time last year at the 10 years anniversary of our center, and I invited you and you came all the way, and since then we have quite a good contact. It's the second time I'm speaking on this kind of conferences in Canada. I should mention that we have two main organization patient groups in Germany, and I'm serving on the board, on the scientific board of both of these patient organizations, and I very much support this interaction between patients and physicians. Though the topic breakthrough, that is already fact, not fiction, diagnosis and therapy of neuroendocrine tumors. I have chosen this title because we have now a 10-year experience in our center in Bad Berka. Please don't say Bad Berka. Bad means spa, actually, in German. It's a very nice place. Not as busy as London, Ontario, or London, UK, but it's in the middle of nowhere. 2.5 hours from Frankfurt Airport by train, so you can leave the train, you can leave the plane and jump onto the train directly in the airport, and you end up in our center. We have a nuclear medicine ward, and I'm quite proud to say it's the largest ward in Germany. Meanwhile, we are doing more than 1,200 treatments with radionuclides, and among them about 500 for radiopeptide therapy. And our department, which is located in this building, came up in 1997 with a PET-CT center now, and also cyclotron available. Okay, this is a patient conference, and I would like to start actually with a patient. With the first patient I treated with yttrium-90 DOTA-TOC at that time, coming from Basel, produced by Helmut Mecker, who is really the father, if not the grandfather, of all these peptides. And I wonder, he's not very often mentioned, but he's a really very essential key person in this production and invention of peptides. And this patient I've treated the first time, I was still in Frankfurt and then left to Bad Berka, was a 15-year-old boy, and with a paraganglioma. And the paraganglioma had metastasized, I think, to any part of the body you can imagine, mainly to bones, to liver, to lung, to everywhere. And this tumor was positive for MIBG, methylbenzylguanidine, which can be used for diagnosis but also for treatment. We started MIBG treatment in 1984. I still remember very well because it was Christmas Eve when we gave the first dose, and I had to stay in the hospital with a small neuroblastoma child. And this boy responded very well to MIBG. He received actually more than 1 curie, or more than 40 gigabecquerels. But then he had a recurrence, and a terrible recurrence causing terrible pain, needed morphine injections, and even chemotherapy was, as you can see, not successful. If you look at the face, I think it tells you more than 1,000 medical records just to look at the face of the patient. And the oncologists say, okay, maybe he might survive 6 or 9 months more. We have nothing to offer to him, so go on with your new treatment and try it. And this is not 2 months, this is 2 years after the first therapy. And you see a whole body scan with a primary tumor, which was very large, about 15 centimeters in diameter. You see a lot of metastases in the spine, in the bones, in the skull here. And by the way, this was a broken arm due to a metastases. He had a pathologic fracture, which caused him terrible pain. And after the first yttrium-90 DOTATOC therapies, his pain within 1 week disappeared completely, and he never needed morphine as analgesics. This is in February 2000, so about 3 years after treatment, after the fourth therapy, and you see reduction in tumor uptake. The patient was doing very well, actually, and then he developed what we call a paraplegia. He couldn't move his legs anymore because of a metastasis compressing his spine, and he had been operated, but it didn't improve very much. But this is actually 5 years after the MIBG and 3 years after starting with the yttrium-90, and he felt quite well. And then we decided, because of this metastasis in the spine, to do something very crazy at that time. We decided to give all the activity intraarterially via a super selective injection into the tumor. So we had a very gifted interventional radiologist, and he did this super selective catheterization of the metastases, and then all the dose was given, and then something happened which really moved me. He could start walking again, even doing jogging, and as you can see, in October 2003, he could play soccer again. For a German, this is very special, of course. And he was doing really, really unbelievable well, needing no medicines at all at that time. And that was the first patient I treated. And you can understand that this was, for me as a physician dealing with patients, with oncologic patients since 25 years, this was really a very, very amazing case. Unfortunately, he died in between, not to his cancer, by the way, but by a pneumonia. This is the youngest patient we treated, a 3-year-old with hepatoblastoma and metastases. Also hepatoblastoma express somatostatin receptors sometimes. Just to show you that this is not a disease of only adult persons or of old persons. We have very young patients, even infants, as you can see here. And I would like to start the more scientific part of my lecture with a pathologist, and this is especially for Sylvia Asa, who gave a very nice talk this morning. And Paul Ehrlich actually was born in Strelitz, which is today a part of Poland, and you heard that Poland is very active in providing radiopharmaceuticals. And he studied in Strasbourg in France and was working as a pathologist. And he was dealing with staining of tissues using different colors. And one of the staining is still used today as what you said in the morning is a routine staining, is hematoxylin eosin, which was actually invented by Paul Ehrlich. And when he used all these colors and tissues and combining them, it came to his mind there must be something specific in these tissues. If one tissue keeps the color and the other tissue doesn't accept the color. And that's when in his brilliant mind, he had the idea that there are amboceptors, he called it. In the morning it was called a lock, and or a receptor, how we say today. And he also had foreseen, by the way, these are hand drawings by Paul Ehrlich, that there are substances not only binding very specifically, today we would say a radioligand binding to his receptor, or a key and a lock, or an antibody and an antigen. It's always the same principle, very specific binding. Look how he differentiated between different, today we would say different receptor types or subtypes already. And he also had foreseen, when you look here, that some substances are given into the bloodstream where you can measure it. Today we call these tumor markers. So without any electron microscope, without fancy molecular biology and millions of grants and so on, he just by thinking about things came up with this idea. And the really important outcome from this idea is that it was not only used for paving the way to what we are using today, but he invented actually a treatment for a terrible disease. Today is not known to many of you that diphtheria at that time killed 30% of children. You know, it was called the death angel of children at that time. And he developed together with Emil von Behring a treatment for diphtheria using antitoxins for diphtheria and also for tetanus. And for that he was awarded the Nobel Prize now more than 100 years ago. Though this is a hematoxylin eosin staining of a carcinoid and a breast cancer. And as you can see later on, specific molecular targets have been used by autoradiography. Now this is a method where you label your key with a iodine 125 label, for example, to show uptake specifically in the tumor by autoradiography. Whereas in this breast cancer you see that there are also some receptors, but much less. And that this is specific was shown by Jean-Claude Reuby from Switzerland, with whom we have a nice collaboration. When you give the cold, agent, the uptake is completely blocked. That is like when you take your chewing gum and put it on the lock, there is no key going into this lock anymore. Now from bench to bedside, this principle in autoradiography with iodine 125 labeled somatostatin, and you heard what it is in the morning, was shortly later used by Eric Renning groups from Rotterdam for scintigraphy, so for external imaging or photoscanning, how it was called at these days, with indium labeled octreotide or OctreoScan, which is still in use today. And also for therapy, so therapy with indium is not, I might say, not very successful. Modern side chains and magic bullets, we have our targets. These can be transporters or G protein coupled receptor proteins or antigens. One famous known to all of you is Herceptin, for example. We have our peptides and analogs or antibodies which bind specifically key and locker principle. And then comes the chelator, which is a cage which takes up our reporting unit and then can be a gamma-emitting radionuclide or a cytotoxic unit like yttrium-90, lutetium, or other therapeutic radionuclides we are using. And this slide was given kindly to me by Helmut Mecke, which shows you the DOTA, which is a cage keeping the radionuclide very stable to the peptide. So when you inject the radiolabeled peptide, it isn't lost from the peptide and really sticks only into the tumor and goes not to normal tissues. And these are these peptides, the chemical formula. Now there have been many, many different compounds. DOTA, octreotide, toctate, noctate, boctate, what, DOTA, what. So you can forget about all of this. It's just different amino acids. You have seen that the key fitting into the lock have a specific structure which is very similar to the native somatostatin. And you just change the amino acids, and by that you are changing the affinity of these things. That is how strong a peptide really bounds to the tumor is determined by this IC50, which gives you the affinity, and as smaller the numbers, as higher the affinity. And you see there are significant differences in these different human somatostatin receptor subtypes 2 and 5. And for example, we have used NOC-naphthyl octreotide, which binds with a high affinity to 2, to 3, and some affinity also to 5, whereas OctreoScan does not show a significant binding here. For those interested of you, we have written, I think, a nice chapter in Richard Wall's textbook for PET and PET-CT imaging of neuroendocrine tumors. Just write me an email and I will send you a PDF of that summarizing our experience. So going on with Bad Berka, we started with technetium-labeled peptide scintigraphy, Eda Heinig-Tok, which is now also on the market in Europe from Poland again, by Polatom. It's called Tektretide for imaging of neuroendocrine tumors. I think we started in 2003 using yttrium-90 dotatate, which was new at that time, because it was mainly DOTA-TOC which was used, and also doing intraarterial therapy. And the major breakthrough was use of gallium-68 and this labeled peptide, as I will show you. We later on also started using lutetium dotatate, DOTA-NOC, DOTA-TOC, and so on, though we have used all these peptides in patients, but we are now staying with yttrium-90 dotatate and lutetium-177 dotatate, because the tate has the highest affinity to the subtype receptor 2, which is the most frequent and important in neuroendocrine tumors. Our interests are, of course, in gallium-labeled radiopharmaceuticals, but also in improvement of peptide receptor radionuclide therapy. That means from just experimental cases to a real clinical routine, optimal selection of patients. That is very, very important. You heard in the mornings that many of the therapies used today, especially, I must say, chemotherapy, do not work really specifically. Any patient gets the same dose, the same number of cycles. It doesn't matter what is the molecular signature of the tumor, what is the real biological behavior. And this, I think, is one of the advantages of nuclear medicine, that you can really, in a prospective way, study first the patients and then look if there is a specific binding, which peptide is probably the best to work with, and then go on with therapy. Very important is standardized performance of PRRT, and I'm very grateful to John that he mentions the structure which you need a multidisciplinary team really to work on, and also, of course, trained nurses, radiochemists, and all these things. I mean, it's a really complex procedure because we have to do everything on our own. There is no company, giving us a radio-labeled substance and then you inject it into a patient like you inject an antibiotic. You just open the bottle, make an infusion and infuse it. We have to do everything by our own. We have to order the radionuclides, we have to order the peptides, we have to label the peptides and so on. So it's really a complicated procedure and needs quite an effort to run it. I think what is very exciting, and I will show you that this is really of an advantage, that we are using yttrium-90 and lutetium in combination, and also we can add external radiotherapy in some of the cases, because the biological behavior is completely different. External radiation therapy is high dose, short term. You just receive 2 minutes a day treatment with external radiation, a high dose, 2 gray. Whereas the radionuclide works after therapy for weeks, and if you take a longer lived radionuclide, probably for months in your body or on the tumor. Systematic follow-up is very important, and documentation and database due to time limits. I will not go into this, but you have heard that we are working on an international registry together with London, Ontario, where we started the whole thing, because it was available there as a web-based database, but now we are working with Singapore, where CNET also in Singapore is very active and, for example, recording on the web when I did a lecture there in March. Now, OctreoScan is familiar to you. It's effective for diagnosis and staging. But I think it's now becoming the old standard for imaging of neuroendocrine tumors because of the much lesser sensitivity as compared to receptor PET-CT. Just one example of a patient presenting after resection of a pancreatic neuroendocrine tumor and splenectomy and the resection of a single liver metastasis some months ago. And he had a rising chromogranin A level in serum. So they did ultrasound, they did OctreoScan, didn't see anything. It was judged as normal, but when we did the receptor PET CT, you clearly see there is a metastasis, which is even hard to detect in this contrast phase in the liver. Actually, you see nothing on the CT scan. And of course, you see nothing in the stomach on the CT scan, but you see a small lesion here, which was confirmed to be tumor, and the patient was again operated. The liver metastasis was resected. The lesion in the stomach was resected. His chromogranin A became normal and currently is free of disease. Sensitivity of OctreoScan versus receptor PET CT. This shows you whole body scans with large metastases in the liver and some disease outside the liver, which is shown on the bone scan as bone metastases. But if you compare that with the gallium-68 DOTA-TOC PET CT, it's stunning how many more lesions you see on the PET CT scan. And this is, by the way, from my friend Heiner Biel in Stuttgart, who was among the first to use gallium-68 DOTA-TOC for PET imaging. A recent study from Innsbruck, from Irene Virgolini's group, comparing PET and SPECT, which is an emission computed tomography using a gamma camera, and computed tomography X-ray, shows you that the sensitivity and specificity of PET, especially concerning the specificity, is around 40% better than SPECT and around 30% better than CT scanning. A little bit about gallium-68. It's nothing new, actually. It's old wine in new bottles, because already in 1961, a group from Abbott Laboratories described the first generator. Though gallium-68 actually is on the, market, so to say, since a very long time, but it took years to build a titanium oxide-based generator, which allows you a convenient, fast in-house preparation. Actually, the mother radionuclide is germanium-68, which has a half-life of 271 days. So you have to replace the generator only once a year. You buy one and it lasts 1 year, and you can daily elute the generator. And what ends up after the gallium-68 is stable sin. Now, we started in July 2004 a collaboration with Professor Rösch's group in Mainz in Germany. He is head of the Institute of Nuclear Chemistry there and has still some relation to Russia. He came from East Germany, which was good for him because he is still speaking Russian, and he supplied us with this generator from Obninsk in Russia. And we started using this generator routinely. I mean, there were studies before by Hoffman, for example, et al., using this gallium-68 approach, but nothing was really using it routinely. And just recently, Eckert & Ziegler, a German company from Berlin, offered this version of the generator in a fully automated synthesizer version, GMP compliant. And I think this is very important for routine clinical use if you want to do that. The advantages of PET-CT, of course, it is that it provides functional imaging. You see the PET images, you see the uptake in the primary pancreatic tumor, in the liver metastasis. But localization of the disease is very difficult. Why? Because you actually have no background. The uptake is so specific that you do not see any normal structure if you just look at the PET images. That is why you need something like a CT scan which guides you where is the lesion and shows you, in this case, this is by fusion then a lymph node metastasis and not a bone metastasis. So in summary, I think this generator is really very easy to use. We are doing now about 1,000 studies a year with gallium-68, and you can study up to 10 patients per day. And this technique is really easy to transfer. We have done some collaboration with the International Atomic Energy Agency, and this generator is now in use, for example, in Delhi, in South America, Santiago de Chile, in Singapore. Within 3 months, they established the technique. unfortunately not in Canada up to now. Okay, this is an image by Professor Baum from New Delhi, showing that this method is also working in India and not only in Germany, and this is a slide from Singapore. There's a group from Bologna who also learned the labeling in our department with gallium-68, was even awarded the S&M Image of the Year 2008 for this very unusual metastases, relapse in the left ear and nodal involvement, and this is a pituitary gland. So my prediction in 2004 was, after the first studies we have done, that this could become the technetium-99m for PET-CT. You know, technetium-99m is really the working horse for nuclear medicine and is used daily around the world in millions of studies per year. And I think if you are looking for something similar for PET-CT, gallium-68 has a great potential to make it. A little bit more on the clinical use, staging of neuroendocrine tumors. I think one of the biggest advantages is that you really have a whole body diagnosis, or how we call it today, a one-stop shop. You can look at lung, at liver, at bone, at lymph nodes, at the bowel in one procedure. You do not need 10 different procedures to do that. You can detect unknown primary tumors. We heard from the surgeon this morning how desperate he is to have a method to localize primary tumors. And I think PET-CT can do a very good job for that. And what is very important for our nuclear medicine field, that we can use the method for, restaging the patient after therapy. There were similar cases shown this morning, and I think it's really intriguing that these primary tumors, this is one actually in the jejunum, in the small bowel, remain very small, sometimes just a few millimeter, whereas metastases, here is a mesenteric lymph node metastases, grow to an enormous size. Though there must be something happen, between this primary tumor and the metastases. And we are looking now, actually since 4 years, we are sampling tissues from patients where we sample the primary tumor and we take the metastases from the liver or the lymph nodes, and we are comparing the genetic signature in these tumors using gene chip analysis, which probably will lead to some explanation why the hell the primary tumors are remaining small. And this is a specific feature of only neuroendocrine tumors. There is no other tumor. Speaking about the adenocarcinoma, you usually diagnose the primary tumor in the lung, in the bowel, in the breast. The primary is growing and then it metastasizes. However, with the neuroendocrine tumors, there must be something different. If you look at angioinvasion, lymph angioinvasion and so on, these tumors spread very small and then they turn on a gene or they turn down a gene, I don't know, something happens in any way. Now this is an example of a one-stop shop imaging using receptor PET-CT in a patient sent to our center with known liver metastases. You see also hepatomegaly in this patient and the unknown primary tumor. And even if you look at the so-called MIP image, the whole body image, you see there are more lesions, not only in the liver. There is one here, and if you look at the transversal slide, you see a small lymph node metastasis near the thyroid. Okay, who the hell would think that a primary or unknown primary tumor metastasizes to lymph nodes in the neck? Nobody. Only if you are doing whole body imaging you detect these things. And there is a small lesion here you can see which corresponds to a bone marrow metastasis. It's not even in the bone as you can see here on the CT scan, but there is a small lesion in the bone marrow. That's why, for example, skeletal scintigraphy will not show this lesion. There is no osteoblastic changes. CT scan will not show the lesion. MRI might show it. But who the hell is using MRI looking at the legs when you have liver metastasis? Nobody. So this whole body diagnosis I think is very important. And we could find the primary tumor, which was in this case also in the ileum with some calcification in a lymph node metastasis here. This is another case. I just made it especially for you in the break, in the lunch break. If you look at the CT scan, even when you give contrast or so, you don't see anything on the CT scan, but you see the primary tumor very nicely here on the PET image. Mostly these tumors are hiding in the small bowel or in the pancreas. And even with endosonography, which is a wonderful and very important method to look at the pancreas, you might miss some small tumors. This is again a patient with a lot of liver metastases. And if you look at the pancreas, which goes around here, it seems to be completely normal, right? But if you look at the PET CT scan, you see a small focus of activity, focal increased somatostatin receptor expression, which was actually corresponding to the primary tumor in the tail of the pancreas, metastasizing heavily to the liver. Again, a small tumor, large metastasis. This tumor was then confirmed by endosonography and biopsy. How small can lesions be detected by PET CT? This is a really stunning example. If you look at the whole body, okay, you see that was a patient actually in follow-up after resection of a primary tumor in the bowel, endocrine tumor, and there was nothing suspected. But if you look at the whole body scan, you see lighting up a tumor here with the SUV. This is not sports utility vehicle, but it is actually standardized uptake value. For nuclear medicine physicians, some also call it silly, useless value, but I think it is very useful, especially for quantification, as I will show you later on. And the SUV of 22 is very high. With FDG, the traditional marker, the established marker, you usually have an SUV of about 5, 8, 10, if it is quite high, about 15 or so. So 22 is quite high, and that allows a very good lesion to non-lesion contrast, and this was actually a 6 millimeter neuroendocrine tumor of the pancreas, confirmed later on by the surgeon. And I especially remember this patient because the surgeon was calling me from the operation theater and saying, "Richard, I can't find this tumor. There is nothing." He palpated the pancreas, he looked at it, nothing. So finally he decided, using these images, which we have online digitally actually in the operation room, he decided to do a middle pancreas resection, which is very difficult actually to do technically, but was successful, and the surgeon proved that there was a 6 millimeter tumor. Restaging and follow-up, you heard about all these tumor markers. There are very specific markers in neuroendocrine tumors, like for example calcitonin is a fantastic marker. If the tumor is producing calcitonin, no other tissue in the body is producing calcitonin except from medullary thyroid cells. There is glucagon, which is quite specific, insulin, of course, but also chromogranin, which is a relatively unspecific but nevertheless a good tumor marker. So this is a patient, and you heard this morning, you have to go away from this, theory there is an organ cancer. These neuroendocrine tumors really are everywhere in the body, and they switch phases. This was a pancreatic neuroendocrine tumor producing calcitonin. Usually you think calcitonin can come only from the medullary thyroid. Though this patient underwent dozens of ultrasounds of the thyroid. She underwent CT scan, MRI, and so on. Nobody finds a recurrence of her tumor. On the PET CT, it was lighting up with a SUV of 71, which is really very high. And a surgeon from Halle, Professor Tralle, who is very well known, maybe to many surgeons because it deals in years with endocrine tumor, he said, okay, I will remove this metastasis in the S1 segment of the liver, and it turned out to be a 1.5 centimeter metastasis. And 2 years later, we have done regularly follow-up. The patient is still free in complete remission, and the only thing which is left is a clip from the surgeon here, which shows you where the metastasis was localized. Some more examples on the superiority of gallium-68 as compared to conventional imaging. You see here a small liver metastasis. If you look at the CT scan, you see nothing. You see lymph nodes in the abdomen. You see small bone metastases. This is another one in the vertebra of the spine here, osteoblastic metastasis, which you can also assume on the CT scan. But if you look at this here, completely normal on CT scan, but still there is a focal uptake. And by MRI, which was performed in this patient due to other reasons, we have shown a metastasis of 3 millimeter in size in the bone marrow. So we can really detect very small lesions, very unusual lesions like this one in the heart of the patients. I don't know if you have ever heard of heart metastasis. If there is one case, it's usually published in the literature because it's so unusual that tumors metastasize to the heart. It's not unusual in neuroendocrine tumor patients. We have now more than 650 patients studied, and we found in more than 30 of them metastasis to the heart, like in this case to the myocardium, where you also see a little bit bulging of the myocardial wall on the CT scan, but also around the heart, pericardial metastasis. And this is especially true for patients with a heavy load of lymph node metastasis in the abdomen. Now I'm still searching for the pathologist explaining me why the hell this is connected to myocardial metastasis. There must be some special flow of, I don't know, lymph or so on. But I never found an answer up to now, but maybe some has an idea. Can we treat these patients? I mean, if you treat someone with a metastasis in the heart, probably you think there is a hole and the patient will die or something. You can. We can treat these patients quite well, as shown in this case with a septum metastasis. After a single cycle of therapy, the metastasis was gone. And these patients I remember very well because he had more than 13 years angina pectoris, you know, and underwent 3 coronary angiograms, and they didn't find anything, and they say, okay, the patient has Prinzmetal angina. Prinzmetal angina is a spastic angina without morphologic alterations, and they're putting on calcium channel blockers and so on, and it didn't disappear. But after one single cycle of peptide therapy, the patient was free of his angina. Before and after therapy, again a patient with a glomus tumor, again a rare tumor. Most think, you know, neuroendocrine tumors are of the bowel, lung and so on, but there are other organs like the glomus which can be malignant, grow, destroy the bone here. And this scan was done actually after external beam radiation with 50 Gray. Never radiate a patient with a highly differentiated tumor with external radiation therapy. Is completely useless. Completely useless. This patient was studied about 3 months after finishing his external radiation therapy and showing an SUV of 109. That means this well-differentiated tumor, they do not react in any way to external radiation therapy, but they are very susceptible to radionuclide therapy. Evaluation of therapy response. I just repeat the theme which was given by John already and others, that morphologic imaging is really not the way to, you know, do therapy response in neuroendocrine tumors, because neither WHO nor RECIST, nor the new RECIST, which exists now, address tumor response with biological and metabolic markers. Look at this case. Wonderful CT scan. Very nice anatomy. You can millimeter, you can measure the diameter. But what does it tell you? If you look carefully to this metastasis, there are these darker areas, right? There are whiter and darker areas. And the darker areas actually is necrosis. That means dead tissue. However, you measure still the total diameter of the lesion. Okay? You are not counting the dead tissue. The same here. About 60 to 70% dead tissue. Whereas this metastasis is mostly consisting of living tissue. However, if we use our gallium-68 receptor PET-CT, we can show that the uptake in the tumor lesions is corresponding to therapy response. That means if we have a molecular imaging modality like PET, showing you here the metastases. By the way, you see here 1 on the CT scan, you see 2 on the PET scan. You see a complete remission on the CT scan. You still see persisting disease on the PET scan. And after the second cycle, finally, there is complete remission of the disease. So molecular response is much earlier, precedes morphology as compared to anatomy. Another example, I think a very impressive example of a patient with terrible pain due to a paraganglioma in the presacral area invading the neural, sheets or spaces there. And he had terrible pain, needing hundreds of milligrams of morphine per day. And if we treat him before, after 1, 2, and 3 cycles, you see there is actually no significant change on the CT scan. Even if you look at the PET scans visually, it's very difficult to say if there is any change. After the 3rd cycle, of course, you see change. But look at the SUV. This is before therapy, after 1 cycle, 2nd cycle, 3rd cycle. You much earlier see by quantitation if there is a response. And that is very important to decide, should we go on with the treatment, should we stop the treatment? Is the patient, of course, I mean, I agree with John completely. You know, feeling better is always a very good sign. And actually you do not need any MRI or CT or PET or whatsoever, no tumor markers. If the patient is gaining weight, it's a hit, you know, it's successful. But those patients not gaining weight, being stable clinically, there you need an objective measure. And I have created, based on others who have done this before, like Steve Larsen and Abbas Alawi, for example, something I call molecular tumor index, which gives you actually the uptake of the peptide in the tumor and the morphologic measure by CT or MRI of the tumor size, and by that you can quantitate this much easily. So for the physicians among us, desist using only resist and use persist. I think like Richard Wahl called it now persist, PET response in solid tumors, which gives you more molecular and anatomic response measurement. Some words only very shortly about other markers like F18FDG, fluorodeoxyglucose, which is a glucose analog you just had in your meal. So already in 97 we published a paper in the European Journal that FDG is not very good in neuroendocrine tumors. We have shown this at that time by OctreoScan imaging, which was strongly positive, and the FDG PET being negative. And later on we found that the key 67 antigen, the proliferation rate, is actually associated with the glucose metabolism. So what does that mean? If you have a low Ki67, you will have a high somatostatin receptor expression and no glucose uptake. There are some exceptions, but this is a rule. At least if you have a high proliferation rate, a high Ki67, you always have high FDG metabolism. This is shown in this case, which we call an inverse flip-flop phenomenon, which is FDG positive, so you see the metastases by glucose imaging in the liver, whereas there is no receptor expression in the tumor. This is a very poor prognosis patient, okay? This is another case just recently published by Else Group. I don't know, John, if you have seen the paper. It's one of your patients, okay. It's a very nice, I think a very nice case which corresponds also to our experience. Here is gallium-68 dotatate, showing you a large liver metastasis with central necrosis already and another metastasis. And this is the FDG PET scan of the same patient. And you see only a little of the rim of the metastasis is FDG positive. You know what will cause the death of the patient? Not these big things, this little thing here. Because these big things are well differentiated receptor positive tumors, but these are undifferentiated tumors, you know, with a high proliferation rate, a high Ki67, and that finally, you know, leads to progressive disease and so on. F-DOPA PET, very shortly, I will just tell you that F-DOPA is a little bit difficult to make. It's quite expensive. However, it is useful in well-differentiated serotonin-positive tumors. In other tumors I will not discuss today, like pheochromocytoma, in medullary thyroid cancer, and also in a special indication in children, actually very small children. I will show you later. First I will show this case from Stefano Fanti from Bologna, who has a tremendous experience with DOPA, showing you the whole body PET, and then the PET-CT images with with bone metastasis, in this case a large mediastinal mass, and something which we also have seen. What do you think is that here? Another thing nobody thinks when, dealing with neuroendocrine tumors are breast metastases. We have dozens of patients now with breast metastases. So if you have a breast lesion, it's not always a primary breast cancer. It can be a metastasis to the breast, and you can differentiate that sometimes by receptor PET-CT imaging, but don't forget, breast cancer in 30% also has somatostatin receptors. So you have to ask the surgeon, in this case, to take out the lesion and look if this is a primary breast cancer, which of course has a completely different prognosis than a metastasis to the breast. Liver metastasis and also a bone, actually also bone marrow metastasis in this case. I mentioned this congenital hyperinsulinism, which is a very rare disease, but the children die due to this disease if you are not able, to cut the lesion out, and this can be done if it is a focal lesion, but it cannot be done if it is a diffuse lesion. This is just a comparison by our colleagues from Munich, comparing FDG, DOPA, and DOTA-TATE PET in the same patient, and you see we can really use nuclear medicine, biological markers to characterize disease. This patient definitely has a very good prognosis. All these metastases are not taking up glucose. They are slowly growing, and they are highly differentiated, as shown by the DOPA PET in this case. So for the imaging part, I would like to conclude that receptor PET-CT has very high diagnostic sensitivity and specificity. It is a semi-quantitative, reproducible method, a quite fast protocol which is finished within 60 to 90 minutes. You need not to ask the patient to return 24 or 48 hours like for octreotide imaging. And it is flexible, can be daily used, and for us it has much, much lower cost than octreotide imaging. I never think of the future, it comes soon enough, said Albert Einstein. And I think the real future for our field is, of course, molecular imaging, but even more it will be peptide and specific molecular radionuclide therapy. And in the second part, I think I have still 10 minutes to go or so. Yeah? Okay. Just would like to mention that this is part of the guidelines. I will skip all of that selection of the patient. Just mentioning that we have done now more actually than 2,000 therapy cycles, about 930 with yttrium and more than 1,100 with lutetium. I spoke already about the necessity to determine the receptor status of the patient. This just shows you that you can choose different peptides and that there is a wide range of uptake. Okay, it's not enough to say the OctreoScan is positive. Please treat the patient. That tells you really nothing. What we must know is really what is the uptake in the tumor. And there is from 8.2 to 109, there is a wide range of uptake. Okay? This is how we perform the therapy in Bad Berka. First, we're doing a pre-therapeutic staging using renal scintigraphy, GFR measurement, receptor PET-CT. Then the patient is infused with amino acids to protect his kidney, and then we infuse the radioactivity. And that there are agents like the cellofusin, for example, which very, very effectively block uptake of the radionuclide in the kidney, is shown by that and also by dosimetry. I will skip on that to save time. I think for the future it might be very important to use longer-lived radionuclides like the scandium-44 DOTA-TOC, which we have used for the first time actually in the world, which allows you to image with PET-CT tumors even after 1 or 2 days after injection. Okay, this is our results, the overall response after 3 cycles of therapy. And don't forget, these were all progressive patients before treatment. 50% we have CR, PR, and MR. In 42% stable disease, and in 7.5% progressive disease. Stable disease on MRI. If you look at the paper of Baum, he showed very nicely in his JCO paper that, of course, patients with progressive disease have a poor prognosis. But if you look at this group here, stable disease, complete remission, partial remission, minor response, they all have the same prognosis. Can't be true, right? That just means that CT, MRI, and so on is not able to differentiate these patients from each other. Again, RECIST is not the way to do it. This is a patient, a young researcher in biology, 35 years old, with heavy liver metastases, and we treated her with yttrium-90. And 1 week later, she sent me a postcard from Africa, where she was doing research in the monkeys. It just shows you this is a therapy which really is not affecting you very much. Patients feel quite well after therapy. And some of these patients, even if they have widespread metastases, like in this case, might even be cured, question mark. I mean, this is a patient with liver metastasis, pleural involvement, mediastinal tumor. After several treatments, after the 3rd cycle, complete remission, and this goes on. So progression-free survival in our patients was 44 months, but this is not really, it's a difficult measure to say progression-free. What is more important is really overall survival, okay? Because if you long enough follow up these patients, you can tell how longer these patients live despite having all conventional therapy before. And this is again from the paper from Baum in JCO, and they have shown an overall survival, a median overall survival of 46 months. And this is years more, years, not months, years more than any of the published data with conventional therapy. And we recently, actually last week, analyzed our data. I'm very happy to say that obviously our data are even better. We have a median overall survival of 59 months. Probably it's the yttrium, because lutetium is very effective, but it is not such a sufficient or effective killer as yttrium-90 is. On the other way, yttrium-90 is more dangerous to many tissues. And if you allow me, this is the last case I will present, because it's a new approach. It's a neoadjuvant treatment. So if the surgeon, even at 3 university hospitals where the patient presented, said inoperable, okay, because when you look at these images, you understand why there is really heavy involvement of the vessels, and all said it's inoperable. So we treated this young lady with yttrium-90, quite high dose, 6 gigabecquerel, 4.5 gigabecquerel. The tumor was shrinking very much, and then our surgeon said, okay, now I try it. And he did a Whipple operation, removed the primary tumor, removed lymph node metastases around the primary tumor, and very nice for the patient to follow up after 12 months. And she will come next week again for control, she is in complete remission. So in summary, I think PRRT is effective, even for very advanced cases, and leads to significant improvement of clinical symptoms. Cure in this very advanced disease is rarely possible, but good palliation can be achieved, and sequential combined use of yttrium-90 and lutetium is most effective. Significant kidney damage can be reduced or even avoided by extending the treatment intervals and by using lower therapy activities more frequently. And again, I agree with John saying these patients need interdisciplinary treatment and care, and this is only really possible in specialized centers. The future directions, there will be, just to mention that, new agents. Think about Paul Ehrlich again. you know, and he has in his hand drawing many different things. We would call it different peptides. And now there is a completely different way. What we were looking at were the key and the lock. Okay, this is what we call an antagonist or agonist. And the new way, and this is very surprising, is that the antagonists are better than the agonists. That would be like the key of your neighbor fits to your lock better than your own key. Okay, that's such a surprise. And these are data, again, from Helmut Mecke's group, from Michaela Ginch, who published that in PNAS. Very, very exciting data showing that the uptake of the antagonists is about 300% higher. 300% higher than the agonist. What does that mean? We can be more effective target tumor with the same amount of radioactivity. We can kill more tumor cells, or we can avoid damage to normal tissues. I completely agree with what said very nicely by Silva Asha in the morning, that cancers will be classified by molecular phenotype and signatures. We should give up on the organ site classification, at least in neuroendocrine tumors. And I think one of the most important fields is really lung cancer. Still, all patients with neuroendocrine cancer in the lung are treated as lung cancer patients. This is complete nonsense. They need treatment of people dealing with neuroendocrine tumors. And molecular phenotypes will be determined by molecular imaging studies using what I have shown you, PET or even optical or MRI spectroscopy and so on, and specific probes. And there is still a lot of work to do for us. This is my team, the lead of the radiochemist, the nurses, my colleagues and so on. I'm very grateful for their work. And I'm most grateful to Helmut Mecke in Basel and Frank Rösch for continuous support, to other radiochemists around the world, especially Professor Chong in Seoul, Jean-Claude Reuby in Bern for a very intense discussion, and just recently to Stefan Schulz. This is probably something we should discuss later on, because there are now very good antibodies showing you somatostatin receptors, which was quite difficult in the past, and you have seen that already at the beginning. Thank you very much for your attention.
Thank you very much, Richard. Very impressive. As a former Belgian soccer player, you will understand that we were always afraid when our team had to meet the Mannschaft, the great Mannschaft from Germany. Before we break I think we deserve a break, but before we break for 15 minutes, I'd like to announce a little change in terms of the schedule.